ask Ms. Jones concerning the inequities in the north and people being able to get professions. Everybody that always a strong advocate. I have a 20-year-old son who's probably autistic and just understands. Yeah. So the inequities in the north and people being able to get professions. So great to be here. And also have a 20-year-old son who's probably autistic I am the Algoma consultant for the strategy team. And I try to come to the project love to hear about
Yeah.
Oh, and
I'm Arjun. I am actually in physician and I'm currently at Sioux College and Professor Casano is teaching us. So I'm just here to
Where's the Zoom meeting? Because I didn't want these.
make
Oh.
job prospecting and planning and
Hi, everybody, Suzanne Solitary, I'm one of the technical representatives. So for folks who don't know what PWD stands for, it stands for advisory. A lot of healthcare folks in here, but
Hi, I'm Walter Wysowski. I'm a manager of analytics from hospital. I also do new healthcare 6 months. It's a little baby. All along, much as possible.
Hi, everybody. I'm Stafford and Monto. I'm in the 30th year of policing. For the last year or two, I've been an equity, diversity, and inclusion lead. Prior to that, recruiting, CID and control. Very much part of the community of women, like social equity, persons, equities, their problems in Ontario. So I'm really interested in learning groups that can be help that they need. My name is Debbie Greystone. I'm a nurse practitioner, retired, but not really. I worked at the hospital for about 35 years, and a lot of 14 in Ridge. And after I retired, so I went back to her and I'm doing the same day clinic, which is sort of something. I'm here in the role as board member. I'm on the board and I'm also on board with my baby. How many years ago? 12 years ago, and it was the sort of lead on the student meetings. Yeah, I've been helpful for that. Okay, back here. Yes. Hi everyone, my name is Sarah. I am manager of project practice and clinical education here at the hospital. I'm background. I've been enrolled for about 4 years now. I had a kind of two genetic guide. It's great connection. To do what we do.
Hi everyone, I'm Sean Ryu. I'm a transformation consultant at the Surrey Hospital, and I've been with the hospital for just over 3 years now. But I support our internal project management office, and I also
My name is Carlene Duck. I am the coordinator of the services Algoma. I'm also one of the co-chairs of Hope Alliance, which is our district's independent trafficking coalition, and I'm also equity as well. And, healthcare and social services. equity as a concept really ensures everyone has what they need. And it also helps us identify why people have access to certain social capital and why. And then it helps us kind of question some assumptions that we make and that we take with us as we plan. And then we make sure that we engage our community and target populations to promote well-being and best interest. So I just wanted to set that context for the conversation today, and that's how we really, as an AOHT, aim to provide care and social support. Okay, so we are funded through Ontario Health. We receive transfer payment agreement that basically ties us to projects. And so what we put in our annual plan and the commitment we made as an Algoma Ontario Health team is to make sure by the end of this fiscal year, which is coming up March 31st, which is why I'm speaking to you all about what our work plan is for the upcoming next fiscal, is to make sure that we have tangible steps to improve equity, diversity, inclusion, and that they are planned for. So it's essentially why we're bringing our work plan to you today. And it's a commitment we made to our community. Okay, so a little bit of the timeline I spoke about. A lot of these things you will see on our Algoma Ontario Health Team journey. I will send out, we have a full summary that summarizes all of the things and the key milestones, so you'll get a lot more context as to what I can provide in a 15-minute presentation. So you'll see a lot of overlap on some of these things, but I really wanted to just emphasize that, you know, a lot of the things that we've been doing to try and advance social equity in our community up until this point has been really piecemeal, you know, trying to understand what each organization is doing and how can we do that better as a community. So at first, we kind of jumped in with equitable and efficient distribution of COVID-19 vaccines. So as I mentioned, it was late 2019, early 2020. I think we were approved officially in July 2020, right smack dab in the middle of the pandemic as an Ontario Health team. So that was a kind of our first jump into really, really big projects that spread across many organizations. Then we launched the Community Wellness Bus in April of 2021. Excuse me.
What? Can you explain what that is?
The Community Wellness Bus?
Yes.
Yeah, so Community Wellness Bus is as a mobile approach to providing care, mostly to unattached individuals in the downtown core right now. And what we provide is harm reduction. We have a nurse on site, so she will do wound care, assessments, we'll do referrals, basic necessities. So we have in the winter, all winter apparel. In the summer, we provide you with, you know, a nice refreshing drink, whatever that may be, whatever the needs are for that particular.
So that's actually here in the Sioux then.
Here in the Sioux, yes, we have worked on expanding, and that's the hope in the future. But really, it's that marked kind of a significant, you know, we have a partnership agreement. We have 6 key partners on that project. So that was one of our first projects that we really worked together as an Ontario Health team. We also conducted a citizens reference panel. So that was a person-centered, equitable, and culturally safe care approach. So it was basically a panel of citizens from across Algoma to really help us shape what our initiatives and make recommendations to how we operate as an Algoma Ontario Health team. From that stemmed a sequence of values and principles for which we operate. We also, and I mentioned that there, so we adopted then the guiding values and principles, and we developed an engagement strategy, which is why now we're proud to say we think we have 18 PFAC members that are focused on primary care. We have multiple community partners engaged in all levels of AOHT work. So we have one of our tri-chairs as a PFAC. We have people working on governance subcommittees, working groups, you name it, there's most likely a community partner attached to the work. So we're really focused on co-designing and upstream engagement. So then we also had a series of planning events dedicated to mental health and addiction. So we brought together 27 organizations in May 2022 to really develop a streamlined approach to not only governing mental health and addictions, but also to providing services. And then we also submitted in July a population health management and equity plan. So really making sure we're embedding equitable approaches into all of our planning work. Okay, so in 2022, we actually had, and Maggie was one of the presenters, we had a project curricular that was specifically dedicated to helping our community learn about what organizations are doing to advance EDI, equity, diversity, inclusion, into their organizations, whether that be to support staff, to support patients, clients. And so we had Maggie present, we had Algoma Public Health present, and we had Sioux Area Hospital. So since that point, it was kind of like the kickoff to us really wanting to develop a work plan and a committee dedicated to social equity and how we can really take in a community approach. So a lot of planning and consultation has gone into why I'm here today to share all of our plans since that point. And then we've also held a preventative screening clinic for unattached individuals. For those of you who may not know, unattached with a variety of different definitions, we use it as you don't have access to primary care or you're not tied to a primary care provider, which obviously we know is going to be even more of a challenge after recent announcements. But really using this as an opportunity to figure out what works really well and come at this from a community approach. We also, the transformation office, which is all of us who work for the Algoma Ontario Health Team. We took a 12-week social accountability course through NALSA, which was great. So trying to help build capacity. We also let partners participate in that as well, as just part of our learning and our development. We also held caregiver focus groups, which turned into publications and research that Patty was speaking to. And then we really started then to really focus the work. So we developed a working group focused on social equity, which is all of the work that will be presented today. So, and then I already touched on, we have 18 advisors onboarded into primary care, PFAC.
That's another question.
Sure.
Wondering, looking at this lovely board.
Yeah.
Lots of things going on.
Yes.
I'm just wondering, is there following something being kicked off within the year, some sort of review, opportunities, well done, things that need to be changed? Is there's something like that happens in each of those, or?
Yeah, so for most of our projects, we do what's called PDSA cycles, so plan, do, study, act. And we also do developmental evaluations on all, I would say probably all of our projects and initiatives. We also go through governance reviews. We renew our partnership agreements every year. So yeah, we definitely take a quality improvement approach to most of our planning and when we actually launch. Most definitely.
And so is everybody in the area, are they included in the questionnaire, or however you decide the way to determine that?
So for example, for preventative screening, you would do like a provider and a patient focused survey, something like that. Is what you mean? Or
well, I've never heard of the focus of the provider screening clinic, whatever. And did we have one in Wawa? Is that something we even knew about?
Yeah, in Wawa.
I'm not sure if Wawa Family Health Team does them or not. So we've done them in the Sioux, Huron Shores Family Health Team does their own in Blind River. I don't believe they do it in Thessalon, but definitely looking going forward.
Yeah, question, right? We should know. We should know what's going on. You should
Right.
know what we know. If we don't know, then we should know. Again,
Yeah, and this is why we have these events, so that way we can network and share information and learn from each other. And yeah, definitely we can even connect offline. So ongoing work, these are things that, we always strive. They might not be a point on our timeline, but we're always trying to do some other initiatives that are always ongoing. So like I mentioned, we have the community partners embedded in all OHT work. We actually created a community partnership toolkit, which is now adopted by the ministry as kind of a way for organizations to use best practice tools to embedding community partners into your organizations and that kind of work. We meet weekly, almost bi-weekly with Mamwasing OHT, which has a high overlap with our attributed population. So really developing and growing, soon to have OHT to OHT partnership, which will be really, really exciting. We also had all of our staff and promoting it with partners, Indigenous cultural sensitivity training. That's always ongoing. We're always trying to learn and grow, and make sure that we communicate that opportunity to everyone in the community. We also are completing active offer training, which is focused on francophone services. And then we actually onboarded knowledge keepers from Nogwindamin, who provide services on the CWD, which is really, really exciting. So a big win for us there. Okay, so I mentioned the social equity working group. This is all in the initiatives that we've done so far to really bring in what the work plan will kind of look like. So we've reviewed the status of equity initiatives at each of our partnering organizations. So I don't know if I mentioned the exact number yet, but we are now up to 21 formal partners on the AOHT, which is really, really exciting. So a lot of reviewing what's in each other's strategic plans, what's ongoing work that we could potentially work on together instead of in silos. As I mentioned, we attended we always try to build capacity within our own team and within our partners through education opportunities. So we did a 4-part series that HSPN was putting on called Advancing Health Equity in Ontario Health Teams, which was a really good opportunity to see what's going on across the whole province. There are now 57 Ontario Health teams in the province. So lots of learning from different regions as well, and how we can adapt to the uniqueness of providing health and social care in the North. We are ongoing developing a resource guide for training and opportunity, or training and education opportunities to try and build that capacity of, what social equity is and how you can be more socially equitable. We've conducted many literature reviews about what is best practice and how to really make sure we're hitting the mark. As I mentioned, we reviewed strategic plans of our partners, and we've reviewed what other OHTs have done, and we engage in line and garner support from the Social Equity Committee, which is the committee that Maggie McGoldrick, our moderator today, supports. Okay, so getting a little bit into our work plan, what we aim to do for the next 1 to 2 years and beyond. So we are going to do a research project, which I'll get to after this. So in the next 3 to 6 months, we're hoping to complete the exploring and planning phase. And some medium-term initiatives. So we're going to work with excuse me, local organizations to administer a generalizable and validated survey. What we're talking. And then really hoping to build that equity, diversity, inclusion, education and training. So whether that looks like community education sessions, really developing and sharing our resource guide and things of that nature. And then, 1 to 2 years. So we really want to make sure that we target projects that improve equity, diversity, and inclusion, that will drive improvement. And then, of course, as always, to meaningfully partner and engage with community voices. Okay, so what went into developing the work plan? So this quote really stuck with me, and it has stuck with me through all of the work that we do. It's whole system actions, not healthcare intervention alone, are required to address inequalities in healthcare outcomes. So as you can see today, we have a really good variety of health and social professionals in the room. It really is a community effort. We have an opportunity to advance the care that is being provided in our community together and not work in silos. And it's really an opportunity to understand where we are and the patients that we serve and the clients that we serve. So there's also a move from integrated community-based care. So we really need to deeply understand our attributed population And we need individual level qualitative data to support our efforts. There's also an appetite to replicate this work across regions. So we would be a leader in the north and hoping to share across the northeast. And there's also been a lot of in-kind support from multiple partners to support EDI initiatives. And of course, what other ways she's have done, they've administered surveys, they've adopted frameworks, they've built capacity for training and education, and they have a shared repository of resources. So all things that we're trying to do over the next 1 to 2 years. So we're really aligned with not only the province, but within our region. So I mentioned in the work plan, the research project, this is going to make up a bulk of our work, and really exciting. Our partners approved it. So we got the go ahead. We are hitting the ground running. So what we are going to do is the local health and social care organizations will collaborate to administer a generalizable and validated survey. So for two people in order to develop and determine what health system experiences are system-wide. I say health system, we know that's health and social care, right? So it's all of our organizations working together. So I just want to clarify that. When I say health system, that's what I mean. Yeah.
I would like to know who are your partners in this project, in this research project?
Sure. Yeah, I can, I'll get to that. Yeah. No worries, no worries. I'll get to that because I'm always willing to add people. So I will, yeah, I'll let you know who's involved already for sure.
Megan,
Yeah.
and we're talking social care. I'm just wondering how housing is fitting into this. Is there a big collaboration with MCCSS or what's going on part of
Yeah, so DSAB is one of our core partners. So they are on board with this project as an OHT partner. So they will be collaborating as well. But yeah, housing is a big for sure. So the survey will include an extensive equity-driven demographic session and access to general interaction. So we will use this survey to drive system improvement and for identified population groups or healthcare sector settings. Organizations may implement evidence-informed co-design interventions for low-scoring populations. When I say low-scoring, it means, we're going to measure across a variety of domains. And so say, for example, if I'm talking, I think I have this in the next slide, but I'll touch on it now. If I'm measuring, say, the domain of communication, did my provider communicate in a way that was well understood? How do the results change by all the demographics of respondents? Okay. And then we'll also, so down the line, once we kind of co-design those interventions to get at, some improvements, some prioritized improvements, then we'll re-administer the survey once an appropriate amount of time has passed to really see score changes. So I wanted to touch on the differentiation between measuring experience versus satisfaction. Okay, so measuring experience is what we are doing in this survey because it is an objective measure that measures the interactions. So you would only be contacted if you were, say, you visited an organization within the last 6 months and you want to report on that visit. It's not just an opportunity for our community members to express their satisfaction or dissatisfaction with a particular service. And that way that you get more tangible results as opposed to like polarizing opinion. It's just a little bit easier to measure. It's sensitive to differences in quality across providers. And it reflects the interpersonal aspects of quality of care received. So it's more what we're trying to get at with this research project. And really the accountability is we need to provide higher quality care. And so this is what we're going to use to measure that. Okay, so connecting knowledge with action. So this is kind of like our system translation plan. So we administer on behalf of the Algoma Ontario Health Team, which is neutral. So that way it's not any one organization, but we're going to use our networks to be able to tap into a variety of different community members. So research ethics training will be required for all members of the research team. And we will have a waiver from the research ethics board to make sure that we're moving in the appropriate direction, that OHT principles are being followed, and all of that fun stuff. And then equitable methods of information will be gathered. So then we will compile and de-identify the results. So we need to protect the respondents and also the participating organization. So none of the results, specific results, will be published. What we'll do is we will, the research team will receive, confidential data, which will all sign data sharing agreements. And that particular participating organization can also receive a package of information that's specific to them, but is not shared publicly or within other organizations. But we'll use that to really stratify the results and develop a protocol for how care should be delivered and what our priorities are in terms of initiatives and interventions to help improve some of those markers. The next section, so we will use data to identify high priority populations and settings. So that's exactly what I have mentioned before. So high priority populations will be identified and prioritized based on results. So talking about, if you're low scoring in communication, really diving into what that is. So we'll have focus groups and we'll do qualitative support to really dive in and prioritize work and have our participating organizations implement those interventions. So co-design of evidence-informed interventions, and then each organization is committing to implementing at least one improvement effort. And then once we implement the co-design efforts, as I said, we would re-administer the survey to see where we've improved, and who knows how long that will be, but that's our commitment and that's what we're going to do. So as an appropriate period of time, we will re-administer and see where we've made those changes or where we haven't and why.
One question.
Sure.
When you speak about each organization, do you mean all of the Algoma Ontario Helping partners or just the partners in this particular research project?
Yeah, so we have 21 partners. I can provide you with a list of all of them, so that I don't have to, but if they are a core partner of the Algoma Ontario Health Team, which now there's 21 of them, they've already committed and signed on to be a collaborating partner in this research. Okay. We will always, if you are not a core member of the OHT, I have us on the slide, get in contact with me if your organization would like to participate. Absolutely reach out to me. The more the merrier, honestly. It will just help us gather more data. Yeah. So yeah, we have 21 already signed on. And there, like I mentioned, there's a lot of in-kind support that's already contributed to this work already. So there's a lot of appetite. And it's a tangible project for people to kind of sink their teeth into and get working on. So I did present this to the Social Equity Committee as well. So there's alignment there. And Maggie is on our team already. So yeah, tons of partners, tons of opportunity. So all that to say, yes, we do have 21 already signed on as you're part of the OHT, but there can be more. So does that answer your question?
What I really want to know is in this particular research project, are there core partners that are not the 21 partners, or maybe part of the 21 partners that you already have signed on, but are more involved in this project?
So I think the levels of engagement, how we have an engagement strategy. So depending on what your organization is able to contribute in terms of resource and time support, data management, researchers, etc., you will be able to engage at different levels. Yeah. And so some organizations will be investing more resources and time and energy into the project than others. But the goal is, as a network of health and social service organizations in the Algoma region, we want to administer this survey and come up with a baseline measurement of where do we need to improve to better serve the folks that we support, whether it's in a healthcare session, whether it's down at the shelter, whether it's at the CRC, whether it's in the emergency department, and stratify that data based on demographics as well. So that we have some points to work with. And then also your organization as a member of the AOHT as part of the project, you can also receive data that is specific to your organization. So you can see, wow, I need to improve communication with this set of individuals or in this demographic area. So we're fortunate with the AOHT and in this region to be so well connected that we do have lots of partners, lots of committees, that we actually have a really good mechanism to do this work, as opposed to, you know, larger AOHTs that may be a little more disconnected from one another.
Yeah.
So we're geographically spread out, but you know, we have a pretty big network, and so this is kind of how can we build on that network and set the bar for what the AOHT wants to do, and then two, how individual organizations provide the services.
Yeah, so there's tiers of engagement. I think I have a slide in here too that touches on it. But basically you can contribute as an ad hoc contributor. If you're representing an organization, you know, you could provide us with a list of people that we can contact, and you can even participate on the research team. To answer your question about if there are not 4 partners that are signed officially onto the OHT that are participating, there are. So for Sioux College is one of them. We have actually a lot of good representation from our North and East partners. So we have someone from Iris Place, which is linked to CMHA, but also Community Living Algoma as well. So yeah, there are partners who are not, you know, formally signed on to the OHT, but that really doesn't hinder. We still engage, and they're still really, really a part of the work.
So I just are interested when you mentioned Iris's Place, which is in Walla. I think we have one too, I don't know. And Community Living Algoma. So if they are part of that, and you know people who have been their clients, and they don't get asked to participate, is there some way they can?
That's a good question. That's a good question. I don't even think we've gotten that far. What they contribute to right now is contributing to the working group, and so developing that research.
Okay.
The principal investigator, and I'll get to that too. So our principal investigator for the research project is linked to the Center for Social Accountability through NASA. She will help us develop what that methodology and data collection looks like. So whether that, like I said, there will be criteria. We would have to have access to services within the lab. Again, she'll determine what the time frame is. I think we're looking at about 6 months, but all of those details will come out as the research team develops. Okay. So I touched upon this a little bit, but this is similar to what something might look like, what question. So if we were to measure the experience based on the domain of communication, we might ask in the last 6 months, how did this provider explain things? How often did this provider explain things in a way that was easy to understand? Never, sometimes, usually, always. And then so we would group those answers based on the predefined demographics and see which demographic groups scored higher or lower. And then what we'll do is we'll target some interventions once we kind of co-design with them through focus groups or client interviews to give us a starting point. And I just want to jump off what Maggie said. You know, we have an opportunity. We get data often that's wrapped in a pretty bow that's about your attributed population, but we don't have data that supports this and allows us to advocate for providing better care that is person-centered. So we can have baseline data from this so that we can advocate and have that support to get more funding, better programming, things of that nature.
Will you also be asking not only receivers, but providers of services? How their experience was in terms of maybe time or funding that they get or whatever?
It's a good question. I think we engage providers in a different way, very frequently. We hold frontline sessions, we have leadership engagement sessions. We really want to focus on what the experience is through the person lens first. And oftentimes you can be a person and a provider, right? So we definitely want them to respond based on the care that they receive. And we definitely engage our providers and our partners in different ways.
This too, though, it sets up a framework for that project. If we do this, you want to say, well, now we have this piece of data and we're understanding how the folks that we support are experiencing our care. You know, now we know where we need to improve. We've also set up sort of like a predefined work plan. We're just changing in some of the variables that we can then administer, you know, through organizations. And those conversations have definitely landed on the table. And this is kind of where this was the starting point.
And once we have that data, we'll you know, part of that co-design is really engaging frontline providers, leadership, and then bringing everyone to the same table to see how we can work well. You can go ahead and switch again. Okay, so stay connected with me, please. I know you've had a lot of questions throughout the presentation, but my information is up there. Please reach out to me. You can reach out to info. I manage that account, so whatever one. But does anyone have any questions that they didn't ask during the? Yeah, Debbie.
So who funds the community wellness bus?
So the community wellness bus is a good question. So we have a partner, we're governed by a partnership agreement between 6 main agencies. They are all providing in-kind support. So we have no funding for the community wellness bus at all. We've submitted multiple funding proposals and here we are. So it really speaks to the commitment of our partners to do work that is impactful. We're over now 15,000 visits to the wellness bus since we launched in April. And so lots of good progress there. We added on Group Health Center most recently as a partner. We started off with 5, but yes, so we do a lot of advocating for it. But no, they're all in-kind support. So Sioux Area Hospital provides nursing staff, social workers, addiction service workers. CMHA provides peer support. I don't want to leave anyone else, so I'll just give those so that I don't give everyone and leave someone else. But yeah, so there's lots of support. We also have people who aren't formal partners involved. So John Howard Society also provides someone 1 to 2 times a week, really focused on providing housing support and referrals. Yeah, so lots of partners, even if they're not formally signed.
So like this sounds really great, like researching, you know, getting your data in your eggs in a row to advocate. However, you already know that we don't have equity here in the north. It's not a big surprise. So I mean it's great. I know it's necessary. However, in the interim,
Yeah.
we have a crisis going on right now. So I think this is not the right forum, but I mean, what other actionable items have been done by the OHT? Because I'm sitting on boards, right? So the information that we get is very limited because we don't need to know a lot about operational, but we need to know about the high level sort of strategies and plans. So what other actionable items has the OHT been involved in since its inception?
Yeah, that's a good comment. So there's a lot of them in this presentation as well. But we got that comment when we brought this to Leadership Council. You know, what I had said was just because we're doing this research doesn't mean that the work has to stop.
Yeah.
Of what's going on at each of your own organizations. We know that we work better together. We need this data to support those planning initiatives from a system level, which we know will bring better improvement. So there's a variety of things going on. We actually just submitted multiple funding proposals to already starting one. So Women's Health Clinic through the CRC, or I guess they call it the Sioux Community Health Center now. I did a Model Care Innovation Fund proposal to help support INGs. Lots of good work happening within the walls of our organization. This is going to go on concurrently. We've also done a lot of capacity building and education. I touched on it a little bit. There's so much work to go on. I try to give you, only have a certain amount of time. But really trying to build that training and capacity. Actually, I had someone from the Tamarack Institute reach out to me as well to try and be involved. So yeah,
Very exciting.
Yeah.
Tamarack Institute, and they're fantastic. They're like nationwide sort of innovation hub around social equity, DEI capacity building, poverty reduction strategies. And it's interesting too. So on a social equity committee, and for the few folks that can speak to it, we do a lot of small project-based work. So our next meeting next week, we'll be talking about a grant application that we assisted the Grandmothers Council to do to hold sacred fires at the CRC and get some money so they can do their work. We'll also be talking about another application to bring in some reconciliation training workshops. We've supported, Bush for Good in some of the applications that they've done.
Yep.
So social equity committee, you know, we're not the high level data collectors, but we do bring a lot of that frontline knowledge and experience into this work.
Yeah.
And one of the struggles, and this happens in all DEI work, is that you don't have operational dollars, you know, and even this project is, the AOHT is just the glue that holds all of these partners together. When the data is released and it is time to start putting boots to the ground to do those interventions, we do rely on the goodwill of the partners to actually, you know, invest dollars into the training program. So that's always a bit of a challenge, but, you know, all of that day-to-day community work, whether it's, you know, oh, we need an extra $5,000 to support that. Does anybody know of any opportunities? Can we get a working group together to apply to this? Community wellness funds is in desperate need of coronavirus snacks.
A new bus.
I do love that.
Yeah.
I can't believe, you know, DSAB's like, well, here's an ambulance, turn it into the bus, and we already need a new one, you know? So all of that work still happens on the ground, and it doesn't get reflected publicly in these great big projects, but, you know, it is happening, and it will inform this work going ahead, but
I just think, you know, when you don't see any change at the front line,
yeah.
right, it's discouraging, right? Because it's like, you know, we don't have a land now, we have no HG. Has it made any difference? Not really. It's kind of worse. So,
I think that-
not that you're doing a bad job. It's just you're new, you're a baby, you're growing, right? And developing strategies, but in the interim, well, there's a crisis.
The analogy, and maybe I'm sharing too much here, but the analogy that I like to think of is COVID-19 brought every single organization to the ground, right? And it was shocking in that, you know, it illustrated how woefully unprepared a lot of us were to handle this crisis. But it also forced a lot of organizations to think outside the box, get things together quickly to take care of the people that we serve. When you implement a new strategy or a research proposal, or when you're really starting to think about changing the way you do things, it's like, when I learned to type on keyboard, I was hunting cat, right? And as much as I hunted and pecked, I was only ever going to be able to type 300 words a minute because that strategy did not work. So I had to throw that out and then learn to type with QWERTY, memorize my keyboard, and let me tell you, for the first month, I was drowning. It was a mess. It looked like I had no idea what I was doing. But you had to kind of get that dip so you can get through to the other side. And I feel like that's kind of where what
I also feel like now you can talk to your computer and you can be doing things so much faster. And so this is what this is in that analogy. To me, what this is it is working concurrently with, yes, a crisis that's happening that we do need to acknowledge. But this will allow projects of much lesser importance to actually have proof that they really need help. And we know that that's something that doesn't happen. So for example, I'm a grant writer and I would go all over that data because that data will allow me to just have many operational dollars, many I don't know, dollars for just consultants, for just somebody from the Tamarack Institute to come and tell me, hey, this is how you can implement the strategy for the plan that you have. For two LGBTQ entrepreneurs that never had any supports in all of Northern Ontario, for example, you know what I mean? So I think that there is incredible value in this, and not to not acknowledge that we do have a crisis. Yeah.
Yeah, and we talked about this too, you know, we're talking about administering surveys based on care that they're experiencing right now, and we're about to have 13,000 people that are attached to primary care. I think this is an opportunity for us to think about what really works well, and leverage that and work together as a community and as providing organizations to make a difference. Because like you mentioned, we are in a crisis. That doesn't mean that all of the other good work has to stop.
So they've just made a big announcement about funding for healthcare in Ontario. I read that today. And I'm just, is that going to be given to OHTs to do what we think in this area needs the most put. And I'm thinking specifically of mental health and addictions. I don't know what the initiatives were, but I'm telling you, nothing's changed in Wawa. We still have a lot of mental health. We still have a lot of addictions. There is no care. We don't have enough. And I mean, it's everywhere. There's not enough social workers. There's not enough therapists. There's not enough. And is that money going to be made available so that this group can say, okay, we need to have a psychiatrist. And so that means we are going to help pay for one to finish his education and get his butt up here to the north for 5 years or whatever.
Yeah, I mean, we're in an interesting spot, though. We are funded through the ministry through specific TPA. We're tied to deliverables that we have to reach, but that can't, and we are, it doesn't mean that organizations can't get funding from other places. We are an avenue that we can put funding proposals together, but we actually can't support clinical services in our funding network. Those come from external funding sources.
Can you put forth, can you put pressure?
Absolutely, yeah, absolutely. It's advocacy. We are a network of providers that have all of their own funding involved. But we definitely use it as a network to advocate. So we support oftentimes funding proposals for our organizations because we have the capacity to do that. We have access to data to support that. We are able to consult really quickly with a lot of different stakeholders from multiple partners. So definitely, it's a huge part of our role.
One of the things I'm finding difficult at the moment is that everyone in the medical healthcare system here is really getting slammed against the wall by Joe Public, and I'm Joe Public as well. I don't feel there's enough communication coming out of what we're doing here to the public. What's the media coverage?
For sure. Yeah, it's something we talk about a lot. I think we could do a better job of really, in the north, we don't really brag about what we're doing, right? Like it's, you know, down south. Yeah, for sure. And we talk about system navigation and system translation is a huge part of our work that we're really trying to figure out, whether that looks like community engagement sessions, education sessions, different avenues to help supporting navigating the system and communication about what services actually exist, and also our work too. So there's a lot of different avenues that we use depending what our initiatives are. Project percolators are one of them. This is a chance for us to get involved and get in front of new and also familiar faces. So yeah, no, it's a work in progress for sure.
I just think every time there's a negative article on Sue Today or in the newspaper or on the news, someone should bite back and say, well, we're doing this, we're trying this, we're doing this. There should be some communication back to the public to, you know, take some of the pressure off the frontline nurses and doctors, you know, so they don't get so much heavy criticism. Oh, the doctor doesn't want to write paper, write a report. You know, we all know it's a computer system that won't talk to the others. You know, there needs to be something that will, you know, bite back and tell people that we're trying.
Absolutely.
Perhaps just give me another quick question.
I'm sorry.
No, I'm just thinking about this harmonized information management system.
Yeah.
So we've just spent $1 zillion in Walmart. We are spending it, and I think they are in the Sioux, and they are, you know, trying to come up with this one record system. Oh my God, is it going to get tossed and all get changed, or is it? You know, we're all going to be using the same thing. Anyways, it's just when I look at our finances stuff, and my heart skips a beat, and I want to vomit and say, okay, we're going to be really poor in 5 years. Is it going to get worse?
No, I think I don't know that we'll, speaking candidly here, I don't know that we'll ever get to a point where there's only one system. Primary care and acute care use totally different systems. But what that really means is how do we leverage, you know, what we can share and being innovative in how we share it. So using kind of digital health platforms, secure messaging, things of that nature. But yeah.
So I worked at the hospital and I work at the group. In a hospital there, When I'm working in merge, I can't see the posting.
Absolutely. Yeah, no, the systems don't talk to each other enough. And that's part of what the planning is. Doesn't necessarily mean you'll eventually use one system. What's that?
They just need to sync up better.
Yeah.
It's so helpful though, when you're working in that environment, to be able to see the historical data on the patient. Because the patient's version is not always the right version.
Imagine in long-term care.
Oh,
Because as soon as they go to long-term care, that's a whole other part, because they have their own system.
What do you think of my doctor seeing a patient and knowing he's getting very cruelly on social media hammered because hammered is not the right word, I think. Getting very cruelly disregarded on social media because he doesn't want to be a family doctor because there's too much paperwork. When in reality, that's not the reason. It's not the reason, but that communication needs to go out into the community to alleviate controls, because that doctor's got to face someone that's gonna, you know, and they're not gonna say,
excuse me, but there's conflict in that. Because some physicians say, no, it's not about the administrative work, and others are saying it is. So until they get their act together too.
We had it, I've been in this exact room this morning, I've been here all day. We had all the primary care providers, not all of them, we had about 25 of them come together to figure out what they are going to prioritize to ask for some alleviating some of those pressures. So they are on it. Okay, so I hate to, cut off the conversation, but we are mostly at time right now. I'm going to hand it over to Jeff. He'll do a very quick update on some of the other work that's going on very, very quickly, and then we'll just wrap up. But like I said, I'll stay if you have any other questions. I'll be around, so feel free to come up and chat with me and Maggie and anyone on our team about any of the work that's going on. And please reach out to me if your organization would like to participate. If you would like to participate, just please reach out to me. Okay? Thanks.
Thank you. Thank you, Cassandra. I'm going to be very brief because I think we're right at 4 o'clock. But yes, my name is Jeff Dorn. I'm a quality improvement consultant with the Algoma OHT. Nice to see so many unfamiliar faces in the room today. So if you do want to come and check out this, if you haven't had a chance, this does outline some of the work that we've been doing since our inception in 2020. But very high level, our main priority populations are healthy aging or older adults who are living with frailty in the community. We know our population is aging quite quickly. We have a growing number of older adults in the community, and so that's been one of our main focuses. So we have a couple of initiatives that have happened in that sort of bucket of work. Some of the main things we're focusing on right now is implementing a post-fall pathway, so essentially a standardized pathway for when an individual does have a fall. They end up in either primary care or in the emergency department. What does the care look like for that individual? What we do know as healthcare providers, or what healthcare providers know, is that a fall can be a really significant event for an older adult and can sort of start the beginning of some significant functional decline for those individuals. So that's one piece of work. Another piece of work is, how can we be more proactive in identifying people who are at risk of falls or who are starting to show some early signs of frailty. So we're working on, and we have implemented a frailty screening process at the Algoma Nurse Practitioner Clinic, and looking at expanding that outward. So here on Shores, the health team recently received some implementation funding to do the same. So we're kind of working through the logistics around that and trying to work that into the clinical workflow at the family health team there. So those are just a couple of pieces of work, small pieces of work. We also have been doing some work in mental health and addictions system planning. So as a couple of us brought up here today, we know that we have a lot of individuals in the community who are experiencing, significant challenges around mental health and addictions. So we brought together partners from across the community. We have involvement from, partners across the district to come together to plan together for a system that's going to be better able to serve the needs of those individuals. So won't get too far into the initiatives that are going on there, but anyone, you know, if you have questions or comments, you know, please feel free to come and talk to me after we wrap up here. And just before we go, a couple of events that are happening. So we have a cervical screening clinic that's happening at the Group Health Center on March 22nd. It's going to be focused on individuals who don't have a primary care provider. So this will be our fifth clinic that we posted. So today we posted 4. We screened 186 people who do not have access to primary care for cervical cancer. So again, share that with your networks, and we can definitely send around that poster. And then another event that's happening. So with that post-fall pathway and that frailty screening work, we really identified a need in the community to educate the public around the significance around healthy aging and you know, what healthy aging means is, you know, we do have, again, an aging population. So we decided that we are going to work together to put on an education series for the community. So the first session is beginning on March 5th. So the topics: healthy aging and frailty, physical activity and staying fit, medication safety, mental wellness, and staying safe in your home. So there'll be 5 presentations. It's going to happen every Tuesday at 3 to 4:30 p.m. At the downtown library on East Street. There's a registration number, so we're going to put out some advertisements next week to start advertising for that. So
Can I just,
yeah,
couple quick things? So in Wallow, we get a bus that comes out of, I believe, Thunder Bay, to do cervical and mammograms and cervical cancer screening. Is there some kind of connection happening here, or is this going to start coming to Wallow from here, or do you have, or do you even know?
yeah, no, that's a great question. So when we had first started planning for the cervical screening clinics, our OHT was more so focused on central Algoma. And then I think it was sometime last year, a year and a half ago, we expanded to include both a portion of what we would consider East Algoma and then North Algoma as well. So just started onboarding partners from East and North Algoma recently. So definitely look forward to connecting probably with someone from the Wall of Health. See what the opportunity.
Okay, so I just hope we keep getting our bus. They're not going away.
Yeah.
Who is this being communicated to? What media are you using?
So there'll be a media release going out next week for this. There's going to be radio ads next week for the Healthy Aging Education Series. Yeah. So and then, you know, by all means, share this with your network.
Can you put it out to the pharmacies? I did one for the virtual clinic, and they were astounded that they didn't know anything about it.
Yeah, this will be going out to the pharmacies. Yeah. So every PAC clinic that we run, those go out to all the IDAs, merits. Yeah.
Another one with the empowering seniors. So we actually had a geriatric kind of nurse in Wawa. Her position first got taken over by an area hospital, so that's who she worked for, although she still works in Wawa. Don't know quite how that program is working, not sure. But perhaps that's something she could be doing in Wawa, is one of these kind of.
Well, they were doing frailty.
They've been doing therapy for years, I think.
Yeah, Jolie.
Mhm,
Yeah.
mhm.
Yeah, so they've been doing frailty screening as well in Wawa,
Mhm.
and have had some success with it too. So great to see.
That's it. Nope.
All right.
Thanks, everyone.
Thank you.
Thanks for coming.